Okay, everyone. I think we'll start now. I hate to disrupt the conversations and conviviality. It's good to see everyone has such a lot to talk about. But I'd like to welcome everyone to this seminar. Welcome to the people who are on Zoom. We can't see them, but hopefully they can hear us. And welcome to our department members and our visitors. For those who don't know me, my name is Chris Jay. I'm an Associate Professor and Medical Anthropologist in the Department of General Practice and Rural Health. And I'm also the Director of the CARE research theme. And I just want to say a little bit about CARE because we're being hosted by the Department of General Practice and Rural Health, but this is a CARE seminar. And CARE is the Collaboration for Ageing Research Excellence. We have a network of some 220 members, I think, and we've been in existence for about 6 years, I believe. So we are committed to exploring and conducting research on issues of older people, health, equity. Next year we'll be trying to apply for centre funding and continuing the good work that CARE does. We do have some leaflets and pens on the sets on the back row, so help yourself to those before you go. Also, just a note on that is that we are recording the presentation today, and that will be available on the CARE website, which is, if you want the presentation, it's another reason to go to the CARE research theme website, and you'll find our newsletters and a lot more about us there. We always welcome new members, so if you go to the CARE website to get the recording, you'll also be able to email us and say, please join us up to your list. So if you're not already a member, we would welcome new members. So just a couple of notes. The Zoom attendees, if you could post your questions to the chat, and we have a CARE member, Meredith, who is standing by to read those questions out. We'll make space for questions both during Peter's presentation. He's happy to take points of clarification. And on Zoom, if you could put them on the chat and Meredith could speak to those. And at the end, Meredith will read the questions on the chat that arise at the end out. We're hoping to have a bit of time for questions at the end. So it is my great pleasure to introduce Peter. He's currently a Professor of Public Health at the Kohata Centre for Haura Māori here at the Otago Medical School. And Peter has made, I don't really need to introduce Peter to us because we know him very well. He's made an enormous contribution to and had a tremendous influence on healthcare in New Zealand as a researcher, an educator and a leader. He promotes social justice and health equity. His contributions in the field were recognised when he was made a companion of the New Zealand Order of Merit a couple of years ago. And he was a panel member for the New Zealand Health and Disability System Review, which was led by Heather Simpson, and we were very grateful to Peter when we invited him to come along and talk to that report. He very generously agreed to come and present the key messages and also what the implications are, where to from here. So I will hand over to Peter now, and thank you very much.
Thank you very much, Chris. Tēnā koutou katoa, and greetings to the Zoom attendees. I've got this little reminder flag in my mind saying stand here so that you can see me. And if I do start wandering around, which I generally do, please can you rein me in and I'll come back to my home spot. Kia ora, everyone. It's a real pleasure to be here. Thank you for the invitation. Thank you to CARE and thank you to the department for hosting this. I'm hoping that we can walk through some material about the review of the health system and then together speculate about what the future looks like. This is very much a tale of two halves, and the second half is yet to be told. And my insights and prognostications will be no more accurate than yours or anybody else's, I think. All right. I'm going to start with some acknowledgements to colleagues who've been part of this journey of the health system review. Firstly, I would like to acknowledge the very large number of groups, organisations and individuals who submitted their views to the review over a 2-year period. So thank you to them. Thank you to my panel colleagues in the photograph on the bottom left there. Heather Simpson, who chaired the panel, is second from the right at the back, standing next to me. And the other panel members are all there as well. And I can talk about them if anybody's curious to know who they are or what their backgrounds are, but I'll move on from that now at this point. The Māori Expert Advisory Group, not pictured, also had a critical role to play in this whole process. Chaired by Sharon Shea, who's currently the interim chair of the Bay of Plenty District Health Board, and also a group of very illustrious people. And they had a big role to play in the conversations that we had. Also, the Secretariat was up to about 20 people, I think at its maximum. Very, very accomplished, hardworking and skilled group of people as well. So this really was a major collective effort. So just some disclaimers from me. I'm only presenting a few key points from the review process and the recommendations of the final report. All the interpretive comments represent my own personal opinion. I'm not seeking to, unless I explicitly specify to the contrary, I'm only representing my views. I'm not seeking to represent the views of others. And also, and this comes back to my comment about the implementation phase, I'm not involved with that at all. And that's where we get into speculation about the future. We do have a few data points on the map now, but still it will unfold as time moves on now that we're post-election. To the Zoom attendees and everyone else here, I'm really happy to take questions or points of clarification as we move through this material. And then there will be plenty of time for discussion. I'll only talk for about half the time that we have, and the rest will be open for discussion. Right, I'm going to talk about the terms of reference for the review. That's important. I'll touch on some of the key recommendations, not all of them, because there's a lot, and we've only got time to refer to a few of them. And then we'll start thinking about what the implications are for policy development here on. The resource documents, well, the work of the panel and the Secretariat resulted in 2 documents. This is the, got the wrong one there, this is the interim report. These are downloadable. That is the best textbook on the New Zealand health system at the moment, in my view. It will, of course, become out of date fairly quickly, but as a point-in-time reference document, there's never been anything quite like it. So I recommend that from a resource point of view or teaching point of view. It's a very rich document. And this is the final report, which looks very similar. Less useful as a reference document because it contains less background information, but this document has all the recommendations in it. And come on. And is a useful document if you want to discern the direction of travel of the panel's recommendations. There is also a summary, some summary documents relating to the 2 reports too. All right, let's move on to the terms of reference. So David Clark, who's just been re-elected to the electorate seat of North Dunedin, isn't it? With a huge majority, was Minister of Health. And he said repeatedly in public that one of his motivations when he took up the role of the portfolio of Minister of Health was that he thought it was time that the country had a look at its health system and went back to first principles and worked out if it was achieving for us what we wished it to achieve. And while there have been many restructurings and partial reviews over the last 3 or 4 decades, there's never been a comprehensive end-to-end review of the health system, working from the point of view of first principles. So that was one of his key motivations to take up the portfolio, because he thought that was a timely contribution. He placed equity right at the centre of the terms of reference, because that was a value which was important to him and the government that he was part of, and also sustainability. He also wanted the review panel to give an indication of the pathway to implementation. So rather than just produce a big report and just say, go do it, our job was also to outline some of the steps and some of the sequencing which would need to occur if our recommendations were to be taken up and implemented by the government. We will come to this at the end, but just to note, we have a new Minister of Health right now, that's Chris Hipkins. We do not know who, when I say new, that's new post David Clark. We don't know who the Minister of Health will be when the government is formed in about a fortnight, the new government. So that remains an open question. It is the job of that minister and of Cabinet in particular to pick up these recommendations and drive them to the extent they wish to drive them. All clear so far? Okay, so I'm going to turn now to the recommendations. The interim report was published in around August last year and set the frame and the foundation for the final report. The interim report gave a strong indication of a direction of travel, but it didn't specify recommendations. It was never intended to. The final report gives a strong indication of a direction of travel. And it's the final report that I'm referring to now in terms of these recommendations. I'm picking out some themes here. So these are quite high level. The first theme that I think comes through in the report quite clearly, and others have reflected this back as well, are themes around accountability and functions. Now, I was part of an oral exam for a PhD yesterday. It was a brilliant PhD at a different university. And the candidate, one of the points I questioned him about, he said, the primary healthcare system is designed around the principle of equity. And I suggested to him that the primary healthcare system is not designed at all. And we by and large have an undesigned health system, let alone around the principles of equity. There are policy statements and intentions which focus on equity, but our system has grown like topsy since the time of the Social Security Act in 1938, which established our current modern system. And just as a reminder, it was, to the best of my knowledge, the first modern health system at a national level in the world in 1938, the Social Security Act. The archetype, Beveridge type system came along 10 years later in 1948 in the UK, post the Second World War. Our system was set up post the Great Depression, of course, which was a moment in political time where major political acts were made possible by the Great Depression, and ditto after the Second World War. In a country dominated by conservative politics, a Labour government was able to introduce the National Health Service. However, it was only, sorry, did someone, yeah.
Yes, question online. Could you please clarify whom equity applies to? Does it also include Pacifica and other groups?
Yeah, thank you. In the terms of reference, equity was used very broadly. The panel interpreted the term to mean socioeconomic equity, Māori, Pacific, disability, and other groups where equity principles are particularly important and apply. So very broadly. Does that answer your question?
I think so. Thank you.
So coming back to accountabilities and functions. At the moment, for example, there are confused accountabilities between primary health organisations and district health boards. Their terms of reference actually overlap very considerably. And it's very hard to know where responsibility is sheeted home to. in our current system. So that's the sort of accountability clarity that the panel thought would be important in our system. And being clear about functions and who's doing what and who has responsibility. Another theme was this idea of having a system at all. Does New Zealand have a health system? Question mark. I think we all think of it as having a health system. I am told, and I haven't tested this, that in the National Health Service in the UK, you could walk down the street of any town, bump into a healthcare worker who might be a receptionist or a dentist or a GP or a hospital radiologist or whatever, and you could say to any of those people, who do you work for? And they say, the NHS. That is the answer they give. In New Zealand, if you walk down the street and bump into any health worker, who do you work for? I work for Mornington Health Centre, or I work for the Southern DHB, or I work for community radiology, or whatever it might be. And for me, that's a symbolic point.
Sorry, I'd like to slightly challenge you, Peter, because I think if you asked a GP, they might say, I work for such and such health centre. And if you asked a dentist, they might similarly, they have a lot of private work as well. So it's not completely different from our system in that regard.
Right. Having worked in both systems, would you say that there's more of a sense of a system there?
Oh, absolutely.
Yeah.
I think that's a very fair point. I think it is a point. I think it is symbolic unity in the British health system that is absent in this country.
And that's the point I'm trying to highlight here. We don't have shared values in a particularly deliberate way. I think we do have a lot of shared values, but they're not constructed at a systems level in the way that they probably are in the NHS. One of the things that the panel recommended was a charter for the New Zealand health system, which has not been formulated yet, but it would contain a set of values and common objectives that hopefully nearly everyone could sign up to very strongly to try and unify our very disparate and complex system. One of the themes that I haven't got on here is the sheer complexity and irrationality of our system. I mean, no one in this room, I will posit, and prove me wrong, please, or out there in Zoom land, can tell me why, for example, podiatrists are distributed the way they are, and why you pay for one here and not for one there. And yet we would all agree that podiatry is a critical component of diabetes care. And it's completely haphazard, as far as I can tell, how it's organised. And that observation goes for so many elements of healthcare provision within our system. The mere fact that we have carved off that part of the body and put it over there and charge very large amounts of money to many, many people who can't afford it, particularly adults. And decade after decade, just ignore that. It's truly weird. I find that quite surreal. But there's numerous examples like that. All right, so that's the charter and shared values, and to some extent shared culture, because it's so much about culture, isn't it? A very strong emphasis on equity comes through the report. Whether or not you think we've done enough about it is another question, but certainly there's an emphasis on it, and strongly on Holder Māori, and I'll come back to that in a moment. Contentiously, and I'll explain my use of that word, population health has been put in as a driver of the system at all levels. The contention comes in because a number of my public health colleagues don't think it's strongly enough in there from an institutional design point of view or the architecture of our system. It's not contention about that being a set of organising principles, it's contention about how we've tried to operationalise that. And community engagement is a theme, possibly less strongly expressed, but it is in there and it sticks out to me as a theme. So I'm moving on from some of those themes. I'm now going to dive into some of the more specific details. Starting with system architecture, according to the review panel, and of course, whether or not this is implemented along these lines remains to be seen. So this is the world as the report recommends. Ministry of Health in the centre there. Ministry of Health there. Now, these two are new organisations at the centre of the system. One of them is called, has a holding name of a Māori Health Authority. And I'll come back to that in a minute. And the other one has a holding name of Health New Zealand. Health New Zealand has the role of having overall responsibility for the service delivery arm of our health system. So it's like the NHS executive, as it were. So the panel is of the view that that would have a different culture from the Ministry of Health, a different set of skills, different set of emphases. Its board would be made up of 50% Māori, 50% non-Māori, and a lot of those people would be chairs of district health boards who collectively take responsibility for the whole system, not just their bit of it. So there's a strong emphasis on whole of system performance here. The Māori Health Authority was the point of some contention, and there were two sets of views expressed in the report. The main view, which I don't agree with, which is that it has an advisory and monitoring function and works in partnership with other components in the system. So much along the lines of the Māori Health Directorate and the Ministry of Health right now. The other view, which I do support, and a number of us did, was that the Māori Health Authority would have a major commissioning role, as well as those other things I mentioned. And that means it would have a very meaningful budget, and it would have the capacity to direct resource and strongly influence the health system. If we've got time, we can come back to that point. So that's overall systems architecture at the centre. And down here, we have community-based organisations. District health boards are the teal-coloured dots, and other regional entities, and of course, primary healthcare and all those other community-based organisations, which we termed Tier 1 in the report as a grouping of community-based healthcare provision.
Peter, question here online. Just thinking about that systems architecture, was there, and you may be coming to this later, but was there much discussion or thought around robust data collection systems across this?
Yes, I'm not touching on that in the slides, but there's a whole chapter on that. And in fact, we expressed our views with considerable urgency on that point around the information infrastructure for our health system. So huge emphasis on that. And it's not otherwise mentioned in these slides, but just to say yes. And we spoke a lot about that in the report. And we believe, all of us believe, this was, I think, unanimous, there needs to be considerable investment from now on in getting our information systems to a more fit for purpose state.
Peter, just a question on the way that this is envisaged in terms of the commissioning responsibility. I'm assuming it sits with the, can you just describe in two versions of the Māori Health Authority where commissioning would sit in this particular schematic?
So commissioning, the key commissioning role in this schematic sits with the DHB still, but with clearer responsibility and accountabilities, including all of what we call Tier 1, what otherwise called primary health care and community-based care, with quite a lot of commissioning oversight and direct involvement for national commissioning from Health New Zealand. So some boundary in there yet to be determined. So some tertiary services, for example, would be commissioned at a national level. Some services where it makes sense to commission them at a national level will sit with Health New Zealand, otherwise with district health boards. The Māori Health Authority, with the alternative view as it's called, would act as a commissioning agency working in partnership with the other commissioning agencies in a coherent, joined up way, which a number of us feel is achievable and which is a very positive disruptor which could change the trajectory of the New Zealand health system. Others, including the chair, thought that would not be possible. But that was a difference of view. Does that answer your question? Right. I've got a whole lot of detail here, which I'm going to flick past. So just look at the slides and just see what the headings say so you know that the information is there. We touched on that. Population health, we've touched on Holder Māori, we've touched on, and the alternative view, which is the Māori Health Agency's commissioning role, we have touched on as well.
Peter, another online question, sorry. So thinking about this sort of potential new vision here, most DHBs have not proved able to embrace primary care needs nor shift those resources. Could you talk us through how you think this new proposal might do this differently, better?
Yeah, it's a great question, and in fact that question could be applied with a minimal rewording to so many components of the health system. And I just want to draw a very clear distinction now between behaviour and culture and structures. So that's a very good question, and it, by and large, to my mind, doesn't invite a structural response. Structures will not determine good behaviour as a generalisation. So we're trying to change behaviour to enable district health boards to be really effective commissioning agencies for tier 1 community-based services, including all of primary healthcare, right? So that will be done through accountability structures, culture, support, enhancement, expectations, etc. Those sorts of mechanisms, rather than through structural mechanisms. Now, I'm not being nihilistic about structure here, and the very clear accountability of Health New Zealand, remember one of those central agencies, for the effective commissioning of community-based services, and its collective responsibility for the whole of the country, we hope will encourage the sorts of behaviour and culture that are necessary for there to be effective commissioning at the level of the community. Does that go some way towards answering that question?
I think so. I think so.
Question, sorry. What you've just said, does that imply a different model of funding for general practice in particular?
I'll come to that now. I'm only going to flick over a few things now because we'll run out of time. So these are tier 1 recommendations. So tier 1, remember, is community-based. Very, very loose boundaries here, and we're not trying to overly define those boundaries. DHBs have authority. There is a locality approach, and I'll define that in a little bit more detail on the next slide. There is ring-fenced funding, because the trend data over time suggests that DHBs have responded to the immense pressures they're under by holding community-based funding level and preferentially funding provider-armed services within DHBs. And the evidence for that is in the reports. Equity and prevention being a priority, that's about behaviour and culture. Provider networks, and I'll specify those networks in a moment. Cultural safety and kaupapa Māori services to be provided everywhere as an expectation for all localities. PHOs are not mandatory in the new system. So DHBs may choose to have other contracting arrangements, and PHO service agreements are not mandatory. So that's actually quite a marked change that the panel was recommending. These provider networks, which I'll specify in just a moment, are a network group of community-based services which will be required to work together using joined-up IT systems. So it may consist of a local oral health provider. Nothing changes about that. They stay being who they are and where they are, but they're part of a formal network. Ditto general practices, ditto well childcare, ditto pharmacy, ditto Who am I missing out here? All the other obvious ones at a community-based level. That just shows you what I've just said. Now, don't worry about reading this. That's the list of locality-based services which will be formally networked. And it includes some of those services I've just identified, plus some others, including outreach and palliative care and population-based health services and so on. And one can add in other services. It does not include adult oral health care for reasons which we could discuss, but I believe it should be in there, but that becomes a funding issue. Now, back to that question about funding. So there will be more flexibility, less prescription. That's to take out from this slide. That DHBs will be able to relate from a funding point of view, commission services in a wider variety of ways, which will be tailored to the specific needs of their local population and the configuration of services that they're funding. And I've listed some of the funding arrangements there. The panel did specify that there should be fair pay regardless of locality, and has implied that nurses, doctors, and other varieties of healthcare professional can expect more consistency nationally in terms of remuneration, both in terms of relativities within primary care, but relativities between primary care and secondary care. And I'm running out of time. The future, here we get into speculation. So obviously we have a Labour-led government for the next 3 years with a very strong electoral mandate to get on with their programme of work. And this was an existing programme of work. So I'm assuming the government will read into this that they have a green light on as many of those recommendations as they choose to implement. An implementation committee has been set up, chaired by, or an implementation group with Stephen McKernan at the head of that. Stephen McKernan was Director General of Health in the Ministry of Health during the latter part of the first decade of this millennium. So he's familiar with the territory. And since then he's been working in consultancies, and he's working for EY at the moment. I think his accountabilities go through to DPMC as opposed to anywhere else, so that the Prime Minister will have direct hands-on involvement with any restructuring which might eventuate. And that last point there is that my advice is that we, all of us, feel empowered to have input and provide views into the process of change, if there is a process of change, and I expect there will be. That none of this is particularly set in concrete yet, so we can all have influence where we feel that's important. That's a personal view that I hold. Others may hold a different view, but I think it's really important that as we start retesting some of the ideas, all the stakeholders and groups feel empowered to express views on that. So that is the end of my slides, and that was a huge amount of information in a very short period of time, but it's just scraping the surface of what's in the two reports. And now let's just have a discussion on any of the foregoing.
So how do you want to do this, Peter? Because we've got some questions already that have come through.
And I've got two or three emails here.
And we have our Zoom participants and our floor here, so we'll try and sort of be equitable in terms of how we take questions.
And can I just hand that the equity responsibility over to you?
Yeah, sure.
I was just wanting to know if you looked further afield than New Zealand Force, and it looks like you've looked at the NHS. Is the NHS a kind of a gold standard, and did you look anywhere else?
The answer's qualified no and yes. So is the NHS a gold standard? In some respects, yes. And it's certainly a huge amount of learning can be gained from the NHS. Whether or not it's a gold standard is up for debate.
Right.
And we looked at many countries and drawn evidence from many places. And Heather Simpson and the head of the Secretariat went, and Sharon on the second tour, went on 2 tours together around various countries, including looking at the nuclear model in North America of Indigenous ownership and provision.
Thank you.
There's a question behind you.
Peter, thanks very much for that. Really informative. My question centres around this. It's called the health system, and it's nice to see New Zealand getting a system. But actually, it seems to be more of a disease treatment system. I just wondered whether determinants of health were examined at all in this, in this process. So, for example, at the moment, the Western World Nutrition, poor nutrition now sits as #1 cause of all the problems that we're dealing with. Overtaking smoking, physical inactivity is not very far behind. And we know that there are other social determinants of health. Was there any examination of that aspect of health at all in this, and any drive to do anything about those causes?
That's a great question, Martin. Thank you. Yes, it's a short answer. So, and I skipped over this. When I said that population health is an organising principle of the system, it's a driver, key driver, at every level, at the centre, in each of those central agencies, led by the Ministry of Health. At the District Health Board level, if there are new regional entities in that level, and at the locality level. And that is exactly what I'm referring to, responsiveness to those determinants of health, the drivers of health status. One of the interesting debates centres on whether or not we should have a separate Ministry of Public Health or equivalent, like the Public Health Commission that we had for 2 or 3 years in the 1990s, and whether that benefits from a systems architecture point of view. The pros and cons of that can be debated at length, but it's a very interesting debate to be had. If we're thinking about the determinants of health, do we need a specialised agency, or do we already have it in terms of the Ministry of Health? Or what would need to change in the Ministry of Health to make it the organisation that we wish it to be? And I could go on, but yeah, the short answer is yes.
Can I just see if there's any questions, Meredith?
Yep, so I've got a couple of questions online. The first question is really, you talked about perhaps trying to ensure there's sort of more funding equality in terms of health professionals, but this question is about whether there was any consideration around costs to people, to patients, in terms of perhaps seeing their GP versus going to see someone in the hospital. The community bears the costs in those situations. So what considerations have occurred there?
So there was, because of the focus on equity, there was a great deal of consideration of out-of-pocket costs and financial barriers to access to various services. And there's some incredibly illuminating figures and tables in the interim report, which show the money flows out of people's pockets into different parts of the health system, and pulled together in a way that I don't think has ever been pulled together before. A lot of it you know, some of it you won't know. Financial barriers to access is obviously a key consideration for many services, including basic things like spectacles, hearing aids, oral health care, etc., and of course primary health care. And we did not seek to over-specify how government should fund deliberately, because in the end, those decisions end up being decisions of cabinet. We made our views very clear about financial barriers to access. They should be minimised, but we did not seek to over-specify the levels of co-payment, as it were. I'm disappointed that we didn't take a stronger line on adult oral health care, But the price tag attached to that is huge. And that was a political call, essentially, in the end. And one can debate that endlessly. I personally am in favour of much more accessible oral health care for adults.
Sorry.
Peter, great to talk, thanks. So sometimes the existence of a system or an entity within a system is a reason to keep it just because it exists, and to change from that would be difficult or costly and so on. So there's a reason to be sort of slightly conservative about existing structures. Did you guys have a discussion? I noticed the DHBs are still there, and things like that. Did you have a discussion at all about how conservative or radical you wanted to be in approaching this, or take it on a case by case?
Yeah, endlessly. It's a wonderful question. It's totally at the heart of all the discussions. So some of our strongest critics, and the ones I read most carefully, and for example, Tim Convencel, who's a political scientist at the University of Auckland, wonderful stuff. Read Tim. He has a 2-weekly or monthly column in New Zealand Doctor. He's referred to this a number of times over the last number of months. He's a non-structuralist. He thinks we're going to throw the bits up in the air, cause huge disruption, take productivity out of the system for 10 years, upset people's lives, do a whole lot of damage, and in 10 years we'll get back. I'm paraphrasing his view, by the way. We'll get back to where we are, and then we can start talking about what really matters, which is culture. Culture drives behaviour more than structures drive behaviour. It's very interesting sitting on a panel and hearing every single submitter, bar none, that I can remember anyway, saying we've got too many DHBs, and not to think about that as a potential problem. Now, we've heard more, I might be wrong about the bar none, by the way, but the vast majority of views are problematise DHBs. Too many, too few, too much governance infrastructure in the New Zealand health system, one can debate endlessly. In the end, we made a call, reduce the number to 8 to 12. The exact configuration yet to be determined. Personally, I'm more on the culture, behaviour, positive leadership side than I am on the structural reform side of this. That's where I stand on it. But as I said before, I'm not nihilistic about structures. I think the accountabilities issues, and the example I gave is a good one, PHOs and DHBs, needs to be fixed. That's the structural problem. That's about terms of reference and who's held accountable for doing what. I completely agree with your point that some built-in conservatism about structural change is necessary.
Can we go to another Zoom question, please, Meredith?
Yes, thank you. So this question is really asking around perhaps the focus or perhaps lack of focus in the report, and it's asking why there wasn't so much attention on perhaps workforce distribution in the report, talks a lot more. You do emphasise the importance of health professionals, but when the report came out, it's a little bit vague about actually the numbers of health care professionals of certain professions and that distribution.
Yeah, thank you. These are great questions. So in the reports, both of them, workforce is defined as a key enabler. And there is actually quite a lot of emphasis on workforce. I think it's quite strong, but we have not modelled quantitatively future workforce requirements. My own view is that it's a mistake to try and do that in this sort of report. Quantitative modelling of workforce requirements has one thing going for it, and that's it's always wrong, and it's always wrong. It's still necessary to do that, but there are many ways of thinking about the future needs of the workforce based around scenarios, expert input, advice, the deliberate contemplation of different sorts of futures, which are equally, if not more, informative. So we did not get into a workforce modelling exercise. We did make some quite strong statements around the distribution of the workforce and the necessity, for example, of rural communities having adequate service provision, about, to use the metaphor Mirror on Society, that sort of approach of workforce which is appropriately diverse to meet the needs of New Zealand's diverse communities. We made statements about the health system modelling excellently engagement with people with disabilities by drawing people with disabilities into the health workforce deliberately in all parts of the workforce. So there's quite a lot on workforce, but not quantitative modelling. Although, that said, for those who are interested, there's some incredibly helpful and useful tables and figures related to the workforce as it currently exists as a reference point.
Okay, thank you, Bronco.
Peter, we have basically though a dual health system in this country. We've got the private sector as well. What I'm not seeing in that is the involvement of the private sector. What is the role, what component, because that's quite a big component of the New Zealand health system. How does that interdigitate with what we're talking about?
Yeah, so the terms of reference put a boundary around the publicly funded system and excluded ACC. So ACC was not in our terms of reference and excluded purely private funding and provision. The terms of reference included the boundaries between public funded and publicly provided and private. So the boundaries were important. So within that, of course, all of general practice is in because it's to some extent publicly funded. There is a lot of reference to private service provision. So for example, optometry is nearly all private. So that's in there because it's so important. But we, as a panel, have not sought to, because of our terms of reference, restructure or make recommendations for the private sector.
Can we go to another Zoom question?
Yep, this question is back to equity again. So you have been talking a little bit about equity, which is great. This is seeking clarity on when you're talking about equity, are you talking about equity of funding or equity of outcome? And if we're really thinking about outcome, could you explain where you got to in measuring outcomes, i.e. how will we know that we've got there?
Thank you. So definitely equity of outcome as being the most meaningful way of thinking about equity in this context. Again, I come back to systems design and answering that question because I don't think there's any single answer to that question, and it's context or demographic specific or health condition specific in some instances. So if we have a system which has a driver population health, then that sort of question gets answered at the right level or at the right multiple levels as and when it needs to be answered. So we have a population health or public health informed system, which would have a huge emphasis on equity.
Must have been an interesting debate with the Māori Expert Advisory Committee about the commissioning functions for the Māori Health Authority. I was just interested around how that decision was made. Was it a political intervention? Was it down to the membership, or was it some call?
Peter, you might like to repeat the question. They were struggling to hear.
Okay, so I'll repeat that question and correct me if I get my précis wrong. The question was, how was the decision made around the final recommendations related to the Māori Health Authority in respect of its commissioning function? Was it a political intervention or was it a chair's call? Was that your question? Yeah. So just to say, there was the Māori Expert Advisory Group that we worked closely with. There was one Māori member of the panel, Shelley Campbell, and there were a number of panel members, myself included. And there were Māori members of the Secretariat, all of whom agreed with arguing, at least exploring the commissioning function of a Māori Health Authority. So that was by far the majority, actually, of people involved in the process. The chair of the panel made a call that this was not going to make its way into the final main recommendations. Instead, there is on page 173 of the final report an alternative view, that's what it's called, which describes at a high level potential commissioning functions of a Māori Health Authority, necessarily at a high level, because that option was never explored in any depth by the Secretariat and worked up as a implementable set of recommendations. Does that answer your question?
Thank you.
Okay, another question from the Zoom, Meredith.
Yes, thank you. How realistic is it to have 3 agencies working in partnership? Is it possible that they might actually have competing priorities and therefore be conflicted, and therefore perhaps there would be lack of cohesive progression or cohesive direction?
Yeah, great question. How realistic is it to have 3 central agencies working in partnership? I think the risks that were identified in that question are real risks, very real risks. And whether or not those risks are manifest would be about leadership and culture. To some extent, in my view, they will be manifest just by the nature of the way things work. And the question then becomes, are the net benefits of having 3 central agencies, do they outweigh the disadvantages in terms of friction between those agencies?
Okay, thank you. Is there another question on the floor? Who's next? Yeah, okay, Martin. And then yeah. So,
all right, yeah. So I was just following up on the fascinating question on the decision that's around the Māori Health Authority having commissioning function. I was just wondered whether that option would be open for the future, or is it now set irrevocably so the way it is, the way the recommendations go through?
Yeah, no, look, great question. So in my view, it's still very much open for exploration in the future. And a number of us are still having vigorous discussions about that in various fora and with various stakeholder groups. It's gained quite a lot of traction out there in health sector land as an idea, noting that it does need a lot more working up around the detail. But no, I think it's still there. And I would say that for all of the recommendations in the report, I think they all benefit from input and extra thought and disagreement on occasions too.
can I just, can we go to the Zoom panel for another question, please, Meredith?
Yes, thank you. So just thinking again about ideal system architecture, how much of a challenge was it for ACC to be deemed out of scope?
Well, there are 2 comments there. One is that our terms of reference were very broad and very deep anyway, so it was some relief that it was out of scope. The second answer is the exact opposite. How can one review the health system without including ACC? And certainly the boundary between ACC and the rest of the health system is an incredibly important boundary. And if one is thinking about equity, of course, the whole ACC versus everything else debate looms very large, doesn't it? Does that answer the question? So it's I would say, a matter for further discussion in the future.
And I think we might take a last question now from Jim.
Okay. I just wanted to ask about Tier 1 services, because it seemed in your diagram that these networks, these local networks under the DHBs, it looked as if they were going to be organised by service groups and therefore different from at least the aspiration of PHOs, which were designed to kind of include various kinds of service groups. So that's one part of it. The other part of it is I think that Tier 1 providers would have a lot of apprehensiveness about being under the planning and funding departments of DHBs.
On the first point, the idea is a formally network group of providers providing services to a defined patient population. So not too different in principle from PHOs, but a wider network of service providers.
Okay, so like an extended PHO?
Yes.
Yeah, okay.
Yeah, and it could be a PHO. That is not ruled out at all. Yes, to the second part. So DHBs would need to be resourced and supported and encouraged to do very, very well as primary care commissioning agencies. There would be almost, well, there'd be quite general concern on that point if we look at the status quo, but we're imagining a different future.
Sure. Thank you.
Does that mean that GPs are on a salary?
They could be, but as they currently can be now, that doesn't predetermine that at all.
Okay, I think we should call a halt because I think that we could easily keep Peter here for another hour with questions. Apologies to people who haven't had their questions answered. But I'd really like to thank Peter for a most illuminating talk that's been tremendously educational and a great discussion afterwards as well. So thank you to all our attendees and to all of the people who did ask a question. So. And thank you very much, Meredith, for representing our Zoom attendees team.
Thank you, Peter. We've had 67 people online listening to you. So